Good morning, everyone. We're just waiting for a few more participants to join. They're just streaming in now, so we'll be starting in 1 minute. Good morning. Welcome, everyone. I'd like to thank everyone who's joined us this morning from across the country. We've got participants from just about every province, so welcome, welcome. I appreciate you taking time out of your day to spend the next hour with us on our session on common myths and current challenges with substance use in the post-COVID workplace. Although I'm not sure we can classify our current stage as post-COVID, we are certainly in a different phase than we were 6 or even 12 months ago, and we will one day get through this. I know for me personally, I've got much more optimism than I did even 3 months ago, feeling like there is some light at the tunnel with the vaccination rollouts. My name's Allison Cairns. I'm a senior benefit consultant here at the Leslie Group, and I'll be the moderator for this morning's session. It's been over a year since COVID-19 came into our lives and our workplace, and now is a word that we use on a daily basis. It's affected most of us in some capacity, whether that be physically, financially, or emotionally. And in a recent study conducted by the Conference Board of Canada, 84% of respondents have reported that since the onset of COVID-19, their mental health has deteriorated. Substance use has always been a problem and affected employees and therefore employers in the workplace. However, with our current COVID landscape, that problem has certainly grown and gotten worse, and unfortunately will continue to grow. 500,000 Canadians miss work every week due to poor mental health. This is a huge cost to employers, corporate productivity, as well as bottom lines. Joining me today about the reality of substance use in the workplace and options and solutions for both employees and employers is Elliot Stone, President and CEO of Alavida, as well as John Chapnick from Portage Legal Services. Elliot Stone is the CEO and co-founder of Alavida, the Canadian market leader in virtual substance use treatment. Early in his career, Elliot saw people he loved prevented from getting help they needed and noticed that when treatment was offered, it was often ineffective or too expensive. Fueled by an empathetic curiosity and scaffolded on a decade of international consulting experience, Elliot made it his mission to make evidence-based, non-judgmental care available without barriers to people struggling with substance use. Alavida has helped over 82% of clients regain control over addiction, and Elliot received his MBA from IE Business School in Madrid, Spain. Welcome, Elliot. Our second speaker today is John Chapnick. John is a workplace lawyer and consultant and a chartered HR professional. Before starting Portage, he worked for unions and employers in BC and Ontario for 15 years. Over the past 5 years, he's frequently written and presented on the topic of workplace mental health and substance use, and he also teaches a course on substance use at the law of UBC's Allard School of Law. In addition to his day-to-day HR advice practice, John is a workplace investigator and part-time member of BC's Employment Standards Tribunal and Patient Care Quality Review Board. So before I turn it over to our two guest speakers this morning, two housekeeping items. One is today's session is being recorded. So if you have to leave early or you have a coworker that wasn't able to join this morning, it will be posted on our website by tomorrow afternoon. And the second housekeeping item, like most webinars, all participants have been muted. However, we do encourage and welcome all and any questions. So what you can do on the bottom of your screen, you'll see a little bubble that says chat. So if you have any questions throughout the presentation, just type it in there. I'll be monitoring. So as Elliot presents or John's presenting, I can read out any of the questions. If you ask a question and we know there's an upcoming slide, we may just table that until we come to that slide. So we will get to all questions. And when there's a bit of time at the end of today's session as well for questions. So without further ado, I will turn it over to Elliot. Welcome.
Thank you, Allison. Thank you for the nice introductions. And thank you everyone for joining. Certainly excited to be here this morning and to be talking with you about the work that we've been doing and or kind of how we can change things around substance use in the workplace. And just in terms of like reiterating what Allison said, I think we're really happy to have questions throughout. I think it makes it more interesting and dynamic. So feel free to interject at any point and we'll answer those as they come up as appropriate. And John and I this morning have split the presentation into kind of two parts. So we can both share our experiences and perspectives because we have a bit of different backgrounds. But I'm going to start by covering substance use disorder a bit more broadly and dispelling some myths and things from the worker's perspective. And then John's going to share his experience in working with employers and HR departments on specific cases and really dig into what that looks like from the HR professional, from sort of your perspective in terms of most of the members or attendees this morning. And then towards the end, we're going to talk about solutions and kind of open it up for questions. So 5 years ago, as Allison mentioned, I co-founded Alavida and launched Canada's first virtual rehab service. And this service was a complete reimagining of what addiction treatment can be. It was combining medication and therapy and technology in a way that created a much more confidential treatment experience and one that was a fraction of the cost of traditional rehab. And over the past few years, we've seen hundreds and hundreds of cases and conducted independent research, and we've learned a tremendous amount. I've learned a tremendous amount. Some of those insights I'm going to share with you this morning. But ultimately, our goal as a company at Alavida was always to create something that would better enable employers like you to do more in the workplace around substance use, to be more proactive and to really handle this in a more thoughtful way. And we launched our enterprise trail platform a little over a year ago. It's been very well received, and in the aftermath, and sort of we're still, as Allison said, we're not really post-COVID yet, fortunately. Even when we sent out the invitation, I think things have been surprisingly taken a bit of another downturn since then, but very optimistic. But the response to our service has been even more than before for reasons that we'll cover this morning. But part of our work was really to focus over the past 5 years on a functioning population and what we call work-focused treatment. And to do that, we had to shake off some old ideas about addiction and reframe it into something that's more relatable and more actionable, something kind of like what you see on the screen now, right? Shifting people's minds away from sort of that image of a smoke-filled church basement that we all tend to conjure when we think about addiction treatment, and into a world of doctors and therapists available on your phone. So we're not just talking about living on the streets addiction. We're also talking about Maureen in accounting or Steve in sales. Substance use is all around us, and I'm willing to bet that each one of you have probably thought about someone in your life even since I've started talking this morning. And so today, John and I hope to reframe what substance use in the workplace looks like and the impact that COVID has had on that, and or what you can do to reduce the impact it's having on your organization. And so broadly speaking, there's been a lot of progress in recent years around mental health. I think it's much more approachable sort of now versus 5 or 10 years ago to come forward in general and say that, I'm having struggles with my mental health. I'm not feeling well around anxiety and depression in particular, and in particular in the workplace. And this is on the back of successful campaigns like Bell Let's Talk and others. But there is still a separation between sort of general mental health awareness and or substance use disorder. And the fact is, when we look at the employer setting, 33% of employer mental health issues are substance use disorders. And so you can't have sort of a comprehensive mental health offering and support your employees' mental health without having a specific offering for substance use disorders. It is very much a part of what's needed. And broadly speaking, what that looks like is that 10% of Canadians struggle with a substance use disorder. But the difference with this issue versus, say, hypertension or diabetes is that most people who are struggling with substance use disorders are not getting help. And there are a myriad of reasons why that occurs, but effectively that's a very expensive way to treat a problem. And that makes, substance use disorders the largest unmanaged disease in modern healthcare. And it's costing Canadians about 26 billion annually. And most of that, in fact, is borne out by employers in the way of lowered productivity and or disability costs as well. And COVID in recent times has really just exacerbated an existing problem. You only have to be alive and breathing to understand that we're all a little bit closer to the beer and wine fridge, a little bit more stressed out. And the recent research, sort of these are all numbers that are coming from the past 3 or 4 months, is really confirmed what we already knew. Just again, with all of us having the shared experience of living through COVID, that 19% of people are drinking more. It's disproportionately impacting women who are drinking. 41% of women are drinking more, and opioid deaths have soared to an all-time high. And this is partly a result of decreased access to care due to travel bans. We've even had outbreaks at addiction care facilities, and just a general clamping down of our mobility in a world that is served by brick and mortar facilities. And if we zoom in for a moment on the opioids in particular, because it's really dominated the media landscape in recent years. If we look at the 2020 numbers in terms of opioid-related deaths per 100,000 Canadians, there's a tremendous jump here, 60% up in the first three quarters of 2020. And this is, there are a lot of factors that go into this number, but the leading ones are isolation. When we're talking about opioids, if there's no one around when you're taking opioids, oftentimes, that can mean that there's no one there to save your life. And that's just a difference of now versus sort of pre-COVID. And there's also been changes in the drug supply. The landscape is shifted, and new elements are entering the opioids that are being taken, and that's resulting in more deaths as well. And then again, just not specific to opioids, but to all substances, increased stress and or use is up as well. But part of the challenge here in general, when we talk about substance use disorder and or the opioid crisis, is that the media focuses on this statistic, right? Deaths per 100,000 or opioid related deaths. And while that is tragic and or certainly newsworthy, it's oftentimes also, when we talk about the employer setting, it can be unrelatable, because it creates this world where unless you've known someone who's died of opioids, it really is a problem for them out there. It's not in my organization, right? And I think it's also obscuring a much larger story and a perhaps more actionable one on the employer side. And I wanted to share, just in the same frame of reference here, looking at deaths per capita. If we add another number, to this slide, this is I think we start to see a kind of a picture that's obscured in the recent media coverage of the opioid epidemic, which is that alcohol is a contributor as well, and or a much larger and when we look at per capita in terms of people using and or in terms of deaths, it's actually not even a close comparison between opioids and alcohol. And I think that part of this in the work that we've done at Alavida is really to reframe this again into a more relatable problem. So if we look at this through another lens, say, one more relatable from the employer's angle, alcohol is the most costly substance to employers by far. This is, across Canada, looking at long-term disability and short-term disability costs. You see that, alcohol is by an order of magnitude more expensive. It is what, case managers see day in, day out. It's what we see as a treatment provider day in and day out. And oftentimes, even when someone has an opioid or cannabis or a cocaine problem, for example, there's an alcohol co-occurring as well. And so I wanted to drill into this and thinking about, not just the opioid epidemic or legalization of cannabis, but talking specifically about alcohol and or some common myths around substance use. Just kind of go through a little bit of a lightning round here on misconceptions and myths. And part of this is that, there is a longstanding idea that people with substance use disorder are unable to work. If someone comes forward and says, "Hey, I need help. I think I'm consuming too much of a specific substance or drinking too much alcohol," oftentimes they're sent directly home. And then they're waiting on sort of a series of events that don't involve them working for the foreseeable future. And the reality is that, the majority of people with a substance use disorder today are working. And we see this at Alavida sort of day in, day out. People who are in treatment, even in the most intensive treatments that we offer, about 91% of them are working full time. And if you, again, I used to, when I present this at conferences, I'm always met with, well, if so many of them are working full time, then you must be just treating mild and moderate cases. So we sort of overlaid the numbers with a diagnostic, and we realized that 83% of that 91% were a severe diagnostic. If you look at how the doctor diagnosed them on the way into treatment. And so it's not just mild and moderate cases. These are also severe, but they're functioning severe, right? And so having a substance use disorder doesn't mean that you're unable to work. We haven't, another one is we haven't had any claims, so we don't have any problems. And the reality is even if you haven't had a disability claim related to substance use disorder, 42% of employees that engage in substance use report feeling a decrease in productivity as a result. So this is a huge suck on the organization. This includes alcohol, and sort of over 80% of folks consume alcohol. So this is a major suck on productivity, even if you're not seeing disability claims in your organization. And then, sorry for the kind of bad news for those of you who haven't heard this in the past sort of 5 or 10 years, but the idea that alcohol is, a little bit of alcohol each day is somehow good for you has been completely dispelled in recent research. And there is no healthy level of consumption. Basically, the best thing you can do for your health is to not consume alcohol, but drinking at a low risk level is the second best. But the idea that it is healthy has been well disproved over the past sort of 5 or 10 years. And then early intervention. Oftentimes we talk to organizations who are talking about pre-disability intervention, or when someone's on, I've had 5 absences, or they're on short-term disability, stepping in as an early intervention to prevent long-term disability. But the reality is that's not early intervention when we're talking about substance use disorders. Substance use disorders, in most cases, develop over years, and in many cases over decades. The average age that we see in treatment is late 40s and early 50s, and so that means these people didn't start consuming the substance or drinking alcohol in the past few years. Oftentimes, this is developed over a lifetime and or decades. So there's a lot of time here to take more action and or to do more for people while they're still at work and productive. And then in terms of thinking about, it's helpful to reframe who we're talking about. And I kind of touched on this a little bit so far, but most HR professionals and or folks that I talk to are really familiar with this first group, right? That issue that we had, the disability case or the person we sent to treatment. These are usually somewhat infrequent and usually very expensive when they occur. And while it's important to be able to do something for those cases when they're in crisis and or treat the severe ones, there is for every one of those, there's sort of 8 or 9 folks percolating in the population headed towards a critical event at some point in the future. And we can do something for those people as well. That's the work that we specialize in at Alavida. And I think also adding to that, the loved ones. Oftentimes, it's worth noting that the person who comes forward and or contacts when you sort of implement a substance use disorder service or management service, oftentimes the person coming forward about 30% of the time is actually a loved one. So it is the spouse or parent, and they've got a child or a husband or wife at home who's actually the person with the substance use issue. And supporting them in that journey is important as well, because that can be a huge suck on their productivity if it's not addressed. And so, offering something for them, and you start to see a growing concentric circle of people who are impacted by substance use in a population. And it's not just the sort of 1% or less who are having these serious critical events. It's the unknown issues that are headed towards that, and then also the loved ones of these people, and then you start looking at sort of 20 or 30% of your population who are actually impacted by substance use. And so taking a look at this from the patient's experience, from the worker's point of view, the experience is broken. This is a world where it is almost entirely oriented toward brick and mortar facilities, which creates low access. I mean, this has been exacerbated in COVID, but even normal times, it's quite difficult to get to these facilities and or get into them. If you think about having to travel, but also being put on a wait list. The average wait list times are 17 to 52 days to get into an inpatient facility for substance use. Group-based programming is problematic. There's a lot of, group-based programming is a very helpful element of treatment when done properly, but it's also a significant barrier for people to get into treatment. We do a lot of work with, police and first responders and groups like that, where you can imagine the perception or the fear around potentially arresting someone on Monday and or maybe sitting down in a group session with them on Thursday. And again, whether this is real or perceived, it creates a barrier for people to get into treatment. And oftentimes, someone can go entirely through a process in a workplace setting without seeing a specialist. And this can create a world where we sort of have too much or too little care. We oftentimes meet someone who's kind of putting their hand up for the first time or showing the first signs of having a substance use issue with hospitalization for 30 or 60 days as an option. And I think that's a pretty extreme option, where the other option is effectively to go back to work and try and, work on cutting back. And then these cases also often come with a disability prerequisite. So we see folks come to us privately a lot of times over the years, where we'll go and advocate for them with their employer. And ultimately they're met with, even in the case where they have a very good benefits offering and they're quite confident that they're going to get coverage, the ultimate answer is, do you have an active disability claim? Otherwise, I can't help you. And that's really not good for anyone around the table. That's not good for the employer, the insurer, or the person who's actually having the issue. And even in the case where we see people go into the most intensive types of treatment, say an inpatient facility, the ongoing care once they're returned is often a bit lackluster, right? We still see it as a common practice that people leave those facilities with some sort of the name of someone they graduated with and the coordinates of an AA meeting. And we can do a lot better than that in 2021. But the result here is that we have low engagement in treatment, high relapse rates, and an increasing cost for everyone around this issue. But it's worth noting here that the employer experience is broken as well, right? It's not for lack of trying or wanting to help that employers aren't able to. It's oftentimes for lack of tools, right? In a large employer setting, oftentimes we see a combination of EAP and or traditional rehab service or an inpatient facility, where EAP is just hopefully picking it up and or triaging it to an inpatient facility. In medium-sized employers, oftentimes that's a referral to a public health facility, which again often has a wait time. But the challenge with EAP is that they're not really designed for ongoing issues, and they're not particularly good at identifying substance use, because EAP tends to be broad and shallow. I mean, they are designed to handle a lot of different types of issues, and therefore they don't present as an expert or having specific knowledge around substance use, which oftentimes prevents people from coming forward and or addressing the issue with EAP. And so this statistic here is actually from an EAP industry report, around substance use cases, they're picking up sort of less than 2%. And then with rehab, again, if it is covered or if there's a way to get people into those facilities, the relapse rates are high, but oftentimes it's not really an option for most employers out there. And so it's effectively a referral to a public facility of some sort. And then for small employers, really there is nothing. Even for a company like ours, we specialize in this kind of treatment. There's nothing in my benefits that I could point to if someone came forward with a substance use issue. And so with that, I'd like to turn it over to John. I think he's going to talk a little bit more about this from the employer's perspective and his experience in working through some of these cases. And John, I'll work the slides here for you.
Thanks, Elliot. Yeah, and thanks to the Leslie Group for organizing this, and thanks to all of you out there who are participating this morning. And while I'm at it, I want to give thanks and acknowledge that I'm joining you here today from the unceded ancestral traditional lands of the Musqueam, Squamish, and Tsleil-Waututh people. So quickly, a bit of background about me. As you know, I'm a workplace lawyer and consultant. I worked for unions in Ontario and BC for about 10 years before switching gears a bit and working as the senior advisor for workplace mental health at UBC. And from there, I went on to be the director of HR and labor relations for a low barrier housing provider in the Vancouver area. And then about a year and a half ago now, I decided to start my own private practice, a large part of which involves providing day-to-day support and advice to not-for-profit employers and small businesses related to workplace issues and problems. And so kind of the through line in all of my work over the past several years is that last piece. I provide advice and support to colleagues and clients in relation to workplace problems. So for pretty much my entire career, like many of you out there, at its core, my role has always been to help solve workplace problems. And what do I mean by workplace problems? Primarily, I'm talking about job performance problems, attendance problems, absenteeism, talking about behavioral issues in the workplace health and safety issues, bullying, harassment, violence, discrimination. I'm talking about workplace barriers that get in the way of safe and productive employment for certain employees and give rise to the need for workplace accommodation. Let's go to the next slide here. So, and in this list of workplace problems that I just gave you, I don't include substance use addiction, substance use disorders, because in my view and my experience, those things are not workplace problems. Occasionally, they might cause or contribute to workplace problems, but those occasions are the exception, not the rule. A big challenge for employers, however, is that right now, most of our workplace policies and practices and supports related to substance use are oriented around the mistaken assumption that employees with substance use disorders are themselves workplace problems. And because of this, the standard human resources and employee benefits approach to employees with substance use issues actually tends to create more problems than it solves. And let me give you an example on the next slide. So I worked as legal counsel for a big public sector union for about 5 years. And during that time, I assisted and represented several employees with substance use disorders. And what was I assisting them with? What was I representing? Why was I representing those employees? It wasn't because they had job performance problems, because they didn't. It wasn't because they were intoxicated at work, let alone exhibiting any functional deficits on the job. None of them were showing up to work impaired, and none of those folks were engaging in excessive or disruptive absenteeism. These employees that I was assisting and their substance use disorders were not causing or contributing to any workplace problems. However, at that time, in order to access employer-funded healthcare benefits related to substance use, these employees needed to disclose their substance use issues to their employer. And when they did that, the standard HR and employee benefits approach kicked in. And so here's what happened. As Elliot mentioned, they were sent home indefinitely. Some of them were offered employer-funded health care for substance use, but only one very expensive type of care. And it was 12-step oriented residential treatment, which for most of them wasn't effective. And you remember, these employees and their substance use disorders had not been causing or contributing to any workplace problems, but the workplace and employee benefits response to these employees actually caused a whole bunch of problems for the employer and their business. So, for example, when the employees were sent home, they were initially out of the workplace for months. And during that time, many of them were still being paid or were receiving wage replacement in the form of employer funded sick pay. And that's, very costly for the employer. The employer was also backfilling their positions, usually with casual employees, short-term contract employees, or through overtime, which meant scheduling costs, recruiting efforts, job competitions, turnover, overtime costs. So this was a very time and resource intensive situation for HR and for frontline managers. And for all of these efforts on the part of HR and management, there was no boost to productivity. The employees who were sitting at home had been experienced productive workers. If anything, their absence resulted in productivity losses. Also, many of the employees who had been sent home never made it back to the workplace. And I'm guessing that to this day, some of them remain on employer-funded long-term disability benefits. And I'll just mention one other problem that this approach created. It created a workplace environment that was arguably not conducive to employees coming forward and seeking help for their substance use issues. Because, most people don't want to go off work for months. They don't want all their coworkers knowing the specific details of their healthcare issues. They can't head off to residential treatment for weeks or months, leaving their personal and family responsibilities behind. So arguably, this approach created a workplace environment that was not conducive to employees getting the healthcare that they need. And that in itself is a big workplace problem because we want our employees to be healthy and well. It's good for them and their families, and it's also good for business and productivity. And so all these workplace problems that I've mentioned, sick pay, backfilling, overtime costs, productivity losses, I don't see this stuff getting better in, the COVID or post-COVID world. In fact, insofar as COVID may be increasing the prevalence of substance use issues, the scale of these kind of self-created problems that I described could grow. And so the question becomes, in the example that I provided, how could the employer have potentially avoided these problems? And what would have been better for those employees? And that's on the next slide. Oh,
and
sorry,
John,
Elliot.
can you talk a little bit about also like medical monitoring?
Sure.
And some like, I guess it's predominantly going to be in larger employers and union-based settings, but maybe touch on that a little bit.
Yeah, well, thanks for mentioning that. Essentially, in that model or that approach that I described, another cost created through that approach that is kind of, in many cases, is kind of creating more problems than it solves, if it solves any, is the typical what they would call aftercare regime with that treatment approach, which is more of a less of an aftercare approach and more of a kind of somewhat of a arbitrary framework for ostensibly guarding against workplace safety issues, which is, you send someone back to the workplace and 2 or 3 times a month you do biological screening in the form of urine testing. And, for an employer, employers that cover that cost, it's very costly. If that cost is borne by the employee, it's sometimes prohibitive, the cost of it. And more important than that, the efficacy and the therapeutic efficacy of a regime like that doesn't have much, if any, evidence supporting it. And from a workplace safety perspective, again, the utility of that approach is questionable. And so, again, this approach is creating more problems than it's solving. Does that help, Elliot?
Yeah. That's so you want to.
And so in the next slide, what could we do different? And essentially, you know, for those employees that I assisted several years ago, it would have been great if they could have accessed employer-funded healthcare benefits related to substance use without first having to tell the employer all about their health issues. When for example, when I worked at UBC, I got tendonitis in my forearm. I had to go to physio. I got some massage, needling done, and my employer-funded benefits covered it all. I got better, never impacted my job performance or behavior at work. None of my colleagues ever knew, and of course, why would they? And it's the same for substance use. If those employees who I represented years ago could have accessed confidential, low barrier, convenient, non-stigmatizing, evidence-based substance use care services through their group benefits plan, I think most of them would have probably used those services and benefited from them. And I'd bet most of them would have continued along healthier than they were before and still without their substance use issues causing or contributing to workplace problems. They wouldn't have had to go off work. They wouldn't have had to exhaust their employer-funded sick banks. The employer wouldn't have had to do all the backfilling and recruiting and scheduling gymnastics. No overtime costs, no no employees languishing on employer-funded long-term disability. And that's why I really like the services that Elliot's been building over the last several years. As workplace problem solvers, we've got enough problems to solve. There's no shortage of workplace problems out there. And so we don't need to, and we don't want to create more workplace problems. So if an employee is working safely and productively as their employer, I don't want to mess with that, even if that employee has a health condition or a substance use disorder. What I want as an employer, I want that employee to be able to have early access to good health care on their own time through our extended health benefits plan. That's what I would want. And admittedly, the services that Alavida offers line up really well with that, which is why I'll be honest, I'm a big fan of Elliot and Alavida. When I worked in workplace mental health and substance use at UBC, I sought out Alavida because they were providing something different, and we had an opportunity to provide UBC employees with addiction-related services. And there was nothing out there that looked like Alavida services looked. Giving employees early access through their benefits plan to confidential, non-stigmatizing, quality healthcare for substance use is good for employees for sure. But I got to emphasize, it's also really good for the employer. It will make your job as a workplace problem solver easier. And I really do believe that.
So John, we've had a question come in. So the question is John referring to unionized workplaces only? You can expand on that.
Sure. I think in certain workplaces, certain unionized workplaces, the employer some of the workplaces I worked with when I worked for unions were bigger unionized workplaces where the employer certainly had more funding, and so they could afford this expensive regime that wasn't really helpful and created more problems than it seemed to solve. But I think what I've been talking about today and what Elliot's been talking about isn't exclusive. It doesn't exclusively apply to unionized workplaces. Most of my clients in my practice right now are non-unionized workplaces, and still, when they're dealing with issues related to employees with substance use problems, they're kind of the solutions out there that they're familiar with are the ones that, in my experience and from my perspective, will create more challenges for them than those solutions or those ostensible solutions solve. So I think this discussion applies to both types of workplaces.
Yeah, just to add to that a little bit, I think that it's the sentiment on both sides, from the employee and the employer side, is the same sort of regardless of the size of the organization and or whether a union's at play, which is that both parties are essentially, like, with the system that's in most benefits programs and the culture and sort of policies of employers out there is this sort of sitting on the hands by both parties, right? Until it becomes a very serious problem, because I don't want to come forward if I have a problem and get treatment, because that treatment looks professionally and personally costly to me, right? Even if, again, some of that might be misunderstood. And on the employer side, as John kind of talked through a couple of examples there, oftentimes it can take a single problem and then create 3 or 4 now that I have to manage if I take action on a case. And I think that that's the same, regardless of the size of the organization and or whether a union is involved. The difference with the unionized and or larger employers is that they often, as John said, they have the budget, they have a bit more tools, but frankly, those tools are a bit blunt and not all that effective, and some of them are quite outdated. And so I think that sort of the innovative thinking that we're promoting here is applicable kind of across the board. And I wanted to take a case example, and again, in a world using an Alavida case example, just to kind of allow people to walk a line and what it could look like, and what it does look like for folks who have implemented Alavida programming. And I will say, like, this is an informational session. I'll have coordinates for a demo. If anyone's interested in actually learning more about our services, I'll point you in that direction after, but really just want folks to understand that it can be different, right? And the way that looks is, for example, if we take Sue here, this is a case where, we had implemented a broad service that's open to the entire population, where people can confidentially access our Trail platform and start to learn about substance use and or track on their own time without actually having to speak to anyone. But if they want to speak to someone, there's a care team there waiting to lean in on their case and sort of give them as much care as they want. And this is an example of exactly that. Sue came to us sort of, she accessed through the benefits portal, started doing one of our 14-day challenges. So she's basically tracking her consumption. In this case, it was alcohol, which is, again, the most common. But on day 4, as she started tracking, a member of our team reached out because her consumption was a bit high. There were some other factors that were, flags in our system. So we reached out, offered her an appointment with a physician, an addiction trained physician. On day 10, she sat down with that physician. They start her on a more intensive treatment and offered her a medication and or regular visits with the therapist that's addiction trained as well. Sue didn't miss any work. She saw her physician and therapist regularly. She completed her online modules through the platform, the application on her phone. And she logged in daily and sort of tracked her progress. And on day 9, her consumption had gone from sort of 9 bottles of wine a week to 2.5. And that's a tremendous difference in someone's productivity and or health, right? These are huge changes. And then, sort of 15 months later, I just pulled this actually for this presentation, if we look at Sue now, she's still with us, and she's still logging every day. She's participating in moderated group sessions, so she's kind of a part of our community, but she's working and she's feeling great. And she's actually mostly participating to give back to the community. And all of this happened without anyone at her work ever knowing anything about it, right? And this is someone who went from sort of severe alcohol use disorder in this case to a very managed level of drinking and or feeling good about herself and productive in the workplace. And this can happen and does happen on a regular basis within our programming and services, but it's a total departure from what we've done historically in this world. And then I wanted to just last here before we wrap up and open for questions, just give a case example on a broad implementation that we did. So there's a health provider network that we launched with Alavida Services. And just to give you a sense, we launched at 5,000 employees, and the initial launch campaign had over 24% engagement. This is people logging in. Again, not all of them with substance use disorders or in need of immediate treatment. These are people exploring, telling talking about their relationship with substance use, learning about what treatment looks like, and or getting educated. And we're on pace right now to, in the first year of implementing with this provider, basically to 15 or 20 to to treat 15 or 20 times more people than they had treated in the prior year, and to do it at basically the cost of treating one of those cases the prior year. And so it's also worth mentioning that this is a particularly problematic area, especially in larger organizations where cases have come through and gone on disability. Oftentimes it's a contentious issue between union and employer. And we have had no negative feedback on our campaign, and actually quite an overwhelming positive sentiment towards what we're doing, and or shifting a conversation that's been contentious into one that's more positive and forward thinking, and really brings, again, benefits provider, employer, and employee to the table in a way that makes sense for everyone, right? More comfortable and cost effective for everyone around the table. And so just as a couple of summary points here, wrapping up the broader discussion, substance use disorder is not a workplace problem. It is a health problem. Alcohol is the most costly substance to employers, despite the media coverage of cannabis legalization and or the opioid crisis. And severe substance use disorder, even severe substance use disorder, does not mean unable to work in many cases. A dedicated solution for substance use disorder is needed if we want to actually change this in the workplace, and confidentiality is really key to successful early intervention. We have to let people know that there's an expert willing to talk to them who is not their employer and who can help them with this health concern immediately. And I think that's a key to really breaking down some of the barriers that we've built up over decades of a traditional way of doing this. And as a final point here, just return on investment is always a big part of a conversation when we're talking to employers and plan sponsors. The Auditor General of the Ontario Mental Health Association did a study that showed that 565% return on investment for making addiction treatment easily accessible to employees. And that is looking at conflict in the workplace, absenteeism, and reduced productivity. It wasn't even looking at disability and or treatment costs. So this is likely understated. But everything that we do at Alavida is really geared towards exactly fulfilling that mission. And I think that I'm very optimistic about where substance use treatment is going, and or in response to COVID. I think it's going to be one of the silver linings of everything that we're going through across the world the past year, is that hopefully we come out with a much better understanding of mental health and substance use disorder in particular, and how we can help people while they're working and productive. But with that, I'll open it up for questions. And I just wanted to touch quickly on also, like while people are typing questions in, if anyone is interested in learning more about the services that we provide at Alavida, and or how you might build that into your benefits offering with your clients or your company, we are doing info sessions, 2 info sessions upcoming on April 27th in French, if there are Francophones on the line, and or May 5th in English. And our head of sales, Yolanda, is also on the call as well. And we'd be happy to hear from you and or book you into those sessions, or talk to you specifically about your company and how we could help. But thank you very much. And thank you, John. And I'm happy to hear any questions there are.
Just while we wait for any questions to come in, I think, the last slide you had, Elliot, there where you talked about it's not a workplace problem, it's a health problem, is huge. That to me for sure is one of the biggest takeaways from today's session. And although we have a lot of employers on the call today, it is a health problem, but has a huge impact in the workplace. And I think that's sort of, with today's session, hopefully people can get something out of it and know that there's options and solutions. So as we kind of wait for any questions that are coming in, I do want to thank both Elliot and John for sharing their expertise this morning. I think for me personally, the session, certainly is disturbing, but unfortunately not shocking based on our current COVID reality and the length of time we've been living in the global pandemic. So the positive news is that there is options and solutions for both employees and employers. I also want to thank all of our participants on behalf of everyone at the Leslie Group for making time to join us today. Okay, we've got a question. Can you provide any details on the referenced medication support associated with therapy? And then they also thank you for a great session and lots of good info.
Perfect. Yeah, absolutely. And so, yeah, this is it's an important differentiator actually, and the work when we first started out, because a lot of traditional treatment is really group-based and therapy-based, right? And you don't often see doctors or hear of medications. And generally, when we say medication and addiction, we're like people, if they're aware of anything, they're aware of methadone and Suboxone, which are a bit more in the news and or heard about through the opioid epidemic. But probably the most innovative and or I think commonly used medications are actually around alcohol use, in a sense that there are about 3 or 4 medications that are non-addictive, and can be prescribed even for mild and moderate cases that really will change someone's relationship with alcohol, fundamentally. And these are medications that are used basically in 2 ways. One is to reduce cravings, if people are abstinent and or when they're not using, to manage their cravings. And then second, it actually, there are some that if they're taken in a targeted way, they can actually reprogram the brain's response to substance, or in this case, alcohol as a stimulus. And what that means is, after a period of taking the medication, effectively, it kind of creates a space in the brain for the therapy to really sink in. Because a lot of times if somebody's been consuming alcohol over, in most cases, decades, right? The auto response on sort of 1 drink to 2 drinks, or when I'm stressed, I have a drink, is often, it's one that's done without much actual thinking. It's a sort of a brain auto response. But taking medication over a period of time can really change that auto response. And these are, again, well researched. They're not experimental medications. They've been approved by the FDA since the 90s. They're just not widely used. And we can lean in on cases and really change people's life at an early stage while they're working with these medications. So happy to share more about that. Sorry, that's a long-winded answer, but this is certainly something that we dig into a bit more in our sessions on the Alavida side.
Thanks, Elliot. So our next question is really around privacy. So I'm not sure if it's who wants to answer it, whether it's better posed to John or Elliot. So why don't I share it with the group, and you guys can decide who wants to answer. From what I understand, physicians are required to report employees to their employer or professional body if they believe the person could pose a danger to the public. Does Alavida have any measures in place to ensure that people can receive services, including being assessed by a physician, without the risk of being reported to their employer or professional body?
Yeah, I can speak to that one. I think that's sort of Alavida directed. It is a great question. I think that, and often, in reality, this is a fairly simple process, right? Like, and it's the same as, the relationship, if anyone on the line has sort of been to a therapist, your privacy is protected 100% unless you're sort of, imminently going to do harm to yourself or to children. There are sort of set rules in place that would break that confidentiality. Those same rules apply for doctors and therapists that work at Alavida. It's not actually an Alavida process that would change that. It's based on the license and or the commitment of that licensed professional. But it's not something that happens frequently. Because again, like I think that reorientation around what severe substance use looks like is often really helpful for people. And when you see, again, sort of upwards of 80% of cases coming in that are sort of severe on the, sorry, I don't mean to do the severe like it's not severe. It is severe. It's a diagnosis of severe, but the difference is that these people are getting up and going to work every day. And oftentimes they're using on their time off or drinking on their time off. And so it is, it's not like it's a question that comes up regularly about being reported to a body. But there are cases, particularly around if someone is, oftentimes it's more around if someone's suicidal, where, it is certainly an obligation to refer them to an urgent care facility and or we have a protocol in place to deal with any of those cases, but they are rare. John, I don't know if you want to add to that at all.
No, I think your answer was great, and I think one thing to note in relation to this question, which I think is an important question, is it seems to me where Elliot and Alavida come at this stuff is from the perspective of not wanting to stop people from working and being productive and managing a health issue, but also keeping their life going. And so that orientation, I think, outside of the most extreme cases, lends itself to a process where you're accessing confidential, evidence-based treatment, and you're not being ushered quickly out of the workplace, if that helps in relation to this question.
I think it's also worth mentioning there that, particularly with substance use disorder, disability, you'd be hard pressed to find a better place to develop a substance use disorder than on disability, right? You're effectively oftentimes the thing that's holding people together is work, right? It's their purpose, it's the structure in their lives. And we've seen a lot of this deteriorate with COVID because even, though people are working, a lot of that structure went away when they went home. And that's part of the reason, and it's the reason that people point to in the research of why substance use and alcohol consumption are up. But taking someone out of work is not just, it's also can be even more, it has a way of leading to a more intense substance use problem, and or can lead to the development of one, even if it's not the first thing that was there. We see a lot of secondary diagnosis with in the world of disability where, it started as a knee injury or, a stress injury, and then someone goes on disability, and then a few months later they have a substance use issue as well, right? And so this work-focused approach is really important for everyone around the circle in terms of getting the best outcomes.
Great. Well, thanks. That is a great answer and lots of good information. So we're coming to a close here from a time perspective. So again, I want to thank all our participants as well as Elliot and John for joining us today. I think we're on a dangerous trajectory when it comes to employees' mental health and substance use. And as Elliot mentioned, it's not a workplace problem, it's a health problem. If you want to look at additional resources, supports, and options for employees, please reach out to your local Leslie Group consultant. We would be more than happy to discuss in detail different options and solutions available for employees' health as well as your organizational health, including but not limited to the programs offered through Alavida. Just a reminder that today's webinar is being recorded. So if you do want to access it later or pass it along to any of your coworkers or colleagues, it will be on our website tomorrow. And hope you can join us for our next Leslie Group webinar, which will be on Thursday, June 3rd. It's sure to be another informative session. And our guest speaker is Drew Taylor, CEO of Acorn Biolabs. So he'll be talking about vaccines and genetics. So stay healthy and stay safe, everyone. Thanks for joining us today.
Thank you.
Take care, everyone.